Yeah, you go first.
Yes. I will share my screen.
Yeah, so today we're talking about asthma, which is very, very broad and very common. It happens everywhere, so it's a good topic. Unfortunately, since it's so broad, we just have to focus on a couple of things. Most likely, we just talk about pathophys today, and then the drugs, how it works. Not much about how to diagnose it, but mainly the treatments and the drugs, which is very big in step one. All right, you can go ahead.
Yes. Hi everyone. Today I will presentation a topic asthma. My case is my patients is a children, not is adult. So it's very it's have some different to adult. I will start. Chief complaint, patient come to my hospital because shortness of breath. 6-year-old boy with past medical history is asthma and asthma come to my emergency department because of shortness of breath. His symptoms start 1 day ago. The first he is cough and wheeze, and then he feels shortness of breath, and more and more, and then his parents give him 2 years and Ventolin MDI 2 times, but it can help him improve shortness of breath. So they decide this bring him to come to hospital. The past medical history, personal, he allergic to screen and now allergic to medication. He was diagnosed asthma 2 years ago, and sometimes he appeared asthma within 1 month ago. He appeared asthma attack from two to 3 times, and he always improved after Ventolin MDI. This is appear at midnight. It doesn't limit to physical activity. Only use Ventolin MDI and when he has asthma attack. About family history, his mother has asthma, and also history he lived in city. And I don't know his family have pet, but his father no smoking. Physical exam, vital sign, pulse 130 times per minute, respiratory rate 48 times per minute, temperature 37.8 degrees, SpO2 from 90 to 93% on room air. Neural system, he was alert. He looked tired and can't answer anxiety sensitive. Sign of meningitis negative. Cardiovascular system pulse were clear. Reactive lower than 2 seconds. Heartbeat were clearly and no murmur. Respiratory symptom. Here breathing, shortness of breath, now apnea, lung reduce ventilation a little, with rents and no sputum. Digestive symptom, he has no vomiting, no diarrhea, soft abdomen, liver and spleen was last during symptom in normal. Blood test normal, chest X-ray has immediate bronchial. He was diagnosed a moderate asthma attack, and he was treated Ventolin 5 mg per time by nebulizer and assessment 15 minutes after, but he can't improve, and he still submit a break appeal to can't improve. So we give Ventolin again and Pumicon by nebulizer, and after that he can feel better. We examine again, and he can improve. So we decided change to respiratory symptoms to treat continue. Diagnosis about this patient, the main disease asthma, accompanying disease, no complication or moderate asthma attack. He was treated by Ventolin and by nebulizer 3 times per day and corticosteroid by oral 1 milligram per day, kg per day within 3 days. And at this slide, I think the plan to treatment in this patient, the first evaluation of severe asthma real level 2 because he has a real from 2 to 3 times per month. It's all the way appear at midnight. About liver of control asthma, I think this patient's ill partial control, and so we give him ICS low dose and SAPA SABA when he has asthma attack. About the and give patient some that's right. He is degree risk factor such as avoid cigarette, smoke, clean house regularly, and don't eat food that he allergic to. Avoid pests and cover nose and mouth if it's cold out. Yes. Thanks for listening. I finished my presentation.
Okay. All right. Very nice presentation. So I have a couple of feedbacks for you first, okay? So
Yes.
like, you know, so people can see that can you share the screen again?
Yes.
Yeah. So basically the red font is the one that I added a little bit. So do you know why I add a 6-year-old boy with past medical history of eczema and asthma?
Sorry. Can you
So,
describe
you
that?
know, when you're opening sentence, when you add, you know, when I add 6-year-old boy with a past medical history of eczema and asthma, why do you think that I added that? Because, you know, when your first sentence is, a lot of people have multiple medical history, but you don't have to put every single thing into the first sentence. You only put the pertinent, you know, past medical history. So do you know why I put eczema and asthma?
I think it's very important because the situation make him to. I think the first it can give me some information to have assessment this patient because it have many reasons so make a break.
Okay, the reason why I put you know, eczema and asthma, have you ever heard of they call it the atopic triad, like a triad of atopy? It's like a 3 allergies that go together. Have you know what I'm talking about?
Oh, I only know about pollen, peanuts, something.
No, it's a medication we call it atopic triad. So it's eczema is one of them, and then we have asthma, and then we have the other one. Okay, let me just type it in for you guys. So usually people with asthma also have, you know, another disease, eczema. So that's why it's relevant. And also allergic rhinitis. You heard of that?
Mm-hmm.
Okay, so usually
Yeah.
allergic rhinitis, eczema, and asthma go together. So if a kid have two, most likely he can also have the other one too. So that's why it's relevant. That's why I put eczema and asthma. So if you pay attention, a lot of people have asthma. We also have eczema. So that's the reason why I added that. Okay.
Mm-hmm.
All right. Okay. So the other thing is I like your history. You know that you put a lot of symptoms that could show that he have asthma. Probably the most important one is the wheezing and the shortness of breath. And then for one thing about asthma, which is, you know, like I told you before, a lot of chronic disease, you need to know the history, the social history part, you know. So I want to see more, where does a patient live, you know, what kind of condition he has. So I'm glad that you talk about there's no smoking around in his house, because certainly smoke can, you know, can cause asthma to become exacerbated. And then also it's no pets. So I like that you say no pets, no smoking. But also, if you can get you know, a sense of where he lives, does he live, you know, in the city where there's a lot of smoke around him, or he lives in the countryside, so there's a lot of hay fever also. So also get that sense of that too. And also, how does he get his medication? Is he compliant to the medications? You know, that's a very important question when you ask a lot of patients. A lot of patients, they sort of, you know, have asthma exacerbation because they cannot get the medication on time. So that's the other thing that you need to sort of ask the patient also. Okay. All right. And just a little bit about, you know, the physical exam. So when you talk about asthma, you need to sort of, you know, do a little bit more physical exam on your respiratory exam, right? So you say there's no you know, no rouse, but what about sputum? Does it have sputum? Is it have an infection?
Yes.
Because some people have asthma and they are predisposed to have an infection, so they could have like pneumonia. Okay. All right. So like just a little bit thing to kind of think about, you know, in the future. So asthma, respiratory. So you got to do a very thorough exam on the lung exam. Okay. So no crackles, no fluids, or you know, no sputum, and that would tell me that there's no infection involved. Okay.
Yes.
All right. Yeah. Nice job. All right. Thank you. Okay. So Hip, you can go ahead. Your show now.
Hold on a second. Wait for me for a second, okay?
Mm-hmm. Okay. So, you know, beside asthma, what would you look for in the patients?
What you mean by looking for?
So what other differential diagnosis that you think of? This sort of easy because, you know, the patient already have a history of asthma already.
I would think about cardiovascular disease first.
Okay.
And then, you know, like through the, and then allergy. I don't know. I don't have enough knowledge to that, but like when I heard shortness of breath, I usually think about pulmonary and cardiovascular, like whether the heart function, like chronic heart failure, but it's a 6-year-old boy, so that's not really.
So the patient is sort of have a past medical history of asthma. So like the first thing you think about asthma, but what else do you think about in the winter? You know, living out. You know of any other symptoms that have similar symptoms in the kids?
In the case, I think this situation come to my hospital. The first I will think about asthma. Besides,
Yeah.
I think from the problem from brain, maybe
How about, you know, like bronchitis, you know, upper respiratory infections?
His
Just a
age
common
is
cold.
6 years old.
Yeah.
Yes.
6 years
So
old.
I
You know,
don't
people
think
have.
about.
Okay.
Yes.
Yeah. So just keep in mind, you know, so because he's out of the range for asthma. I mean for bronchitis, but that's why I asked about sputum.
Yes.
Because if he has sputum, if he has sputum, then you could think about like bronchitis, or you know, if he have any upper respiratory infections like a common cold, like you know, runny nose, then you think about allergic rhinitis too. So okay, all right, Hip, go ahead.
Hi guys, today we will talking about asthma. As we know, right, asthma is a chronic disease, but it's reversible. And the main reason that we have the asthma because of the our inflammation attack the airway. So that's why they symptom associated with the bronchoconstriction. Bronchoconstriction to me is because in our airway we have smooth muscle. So smooth muscle in this case is the hypertrophy and hyperplasia. So that's why they increase the muscle in the airway, so they narrow down the diameter of the airway. So that's why they call bronchoconstriction. That is reversible. So why is reversible? If you remove any allergen away from your body, then you don't activate or trigger our immune response. So that's why it's called reversible. And airway edema and hyper responsive. And it's the characteristics of the asthma is they have a wheezing because at the same reason they narrow down of the bronchi. They have a chest tightness, cough, and a cough in the asthma. It is sometimes it happens at night time, and I don't know why the cough happens at the night time. And sometimes it can also happen to the breathlessness. And the asthma is unpredictable, right? So it can become to the mild attack to the complete airway obstruction. And in a severe case, it's called death if we don't use medication right away. So it can be called very serious. Do you have anything to add to this slide?
No, you can go ahead first. Yeah.
Okay. So for the asthma classification, I think like we have four classification for that, and they are based on the daily activity symptom occurrence and the use of it. So first one is the intermittent. For this kind of intermittent, we don't need the medication daily, but like we only use this medication whenever we need it, and there is no interference with daily activity. So this like can consider like very simple, and the symptom occurs 2 or less than a days per week, and that's why I say like you can wake up from the sleeping because it's have a cough, right? And you want to use some inhaler. I think what I learned is we will use the short-acting beta agonist, right? That's the drug of choice for the acute asthma attack. And as I also want to say, asthma is also related under kind of the COPD, right? Chronic obstruction pulmonary disease. So that's why sometimes in a severe case, the forced expiratory volume also decrease. All right, so I second classification is the mild persistent. So it is a little bit severe compared to the intermittent. So this one is one daily control medication needs low dose inhaled corticosteroid, cromolyn, and a leukotriene modifier. And the thing we use the inhaled corticosteroid is that we want to reduce our inflammation. That's why we use corticosteroid. And sometimes in the man interference with the daily activity, the symptoms occur 2 or more days a week, with awakening from sleep 3 or 4 times a month. Again, it has something associated with the cough. That is one thing. It's related something with a cough. And as I say, we need to use some medication to rescue a symptom. A third one is the moderate persistent. So this stage we look more serious. So we need to inhale beta 2 agonist daily control medication. So in this state, we need to use medication for this asthma. So you combine the inhaled medium dose corticosteroid with long-acting bronchodilator, cromolyn, and leukotriene modifier. And in this state, our daily activity can be interfering with the asthma. A symptom occur daily, waking from sleep at least 1 night a week, but not every night. Again, we have to use some inhaler to rescue our symptom. And in this situation, you can see the FEV1 is low, so it tells our lung function is gradually decreased. And I also want to mention our symptom or sign is happen on the episode, right? Because it is asthma, so they come on and off. And this is the most severe situation. You have the severe persistent. So in this, you use the inhale beta 2 agonist PRN, multiple daily control medication. So for example, you have to use inhale higher dose corticosteroid, long-acting bronchodilator, cromolyn, leukotriene modifier, and maybe with some long-term corticosteroid. So for long-term corticosteroid, you want to use some inhalation, right? We don't want to use some systemic injection because that might make our immune system is compromised. It might be easy to infect by another disease. So that's why it is better to use a long-term corticosteroid by inhalation. And with this severe persistent asthma, they have a major interference with daily activity, right? So you cannot do some heavy walking because asthma related to it. And it's awakening from sleep every night, and we have to use some short-acting beta agonist for this disease. And you can see now the PVE is less than 60%, so it tells our lung function is working very slowly, and it's not at the optimum level. So I think now we can know the PVE from through our, we can know our function working through the PEV, not FEV. All right. So talking about pathophysiology, so we know, right? We know asthma is the disease related to our immune body respond to exchange with allergen. So some allergen will cause our immune cell to get into the lung, and it get some fibrosis and mucus hypersecretion, epithelial injury, smooth muscle hypertrophy, right? So that's why you can have bronchoconstriction because smooth muscle cell is hypertrophy, so they narrow the diameter of the airway. Angiogenesis and the airway obstruction and bronchial responsiveness. So airway obstruction because asthma belongs to COPD, and with the COPD, it is not easy for your lung to exhale the air out of your lungs, so the air will accumulate in your lungs. So that's why you have the hyperinflation. And all right, so talking about, you can see a picture right here, right? This picture right here is show you a normal, hold on a second, a normal airway, right? So you can see right here the oxygen and carbon dioxide travel through the airway, and you can see right here the smooth muscle right here, blood vessel, lumen, and mucus lining. Let's talking about the asthma, right? Asthma, you can see the lumen is narrowed down, and they narrow down because of the hypertrophy of the smooth muscle, excessive mucus, and blood vessel infiltrated by immune cells. And let's say yeah, I think that is the most reason about asthma, right? They redo the airway. So that's why when you do a physical exam, you will hear a wheezing sound on the physical exam.
Okay, so let me take over and talk just a little bit about the pathophysiology of asthma. So the layman term for asthma is basically reversible bronchoconstrictions. That is like, they always ask you what is underlying. So that is like, the terms to describe it. So why is it why do they have to define it as reversible? Because there are some lung disease that are irreversible. For example, COPD is also caused by damaging of the the respiratory system, but it's irreversible. So when people talk about asthma, you think about reversible causes. So when you see, when you look at the lung, so you divide the lung into the bronchi and then the bronchioles. So the bronchi, which is the larger one, and then it go into the bronchioles, and it would be go into the alveoli. So the primary site for asthma is basically bronchoconstriction. So it happened in the bronchioles, not in the alveolar, not in the bronchi. Okay, so if things happen in the bronchi, then we cause bronchitis. So inflammation of the bronchi, and then you have asthma. It went a bit lower down, so we call bronchial constrictions. And when things happen down further, like in the alveoli, and you have like pneumonia, and if you have COPD, then it's alveolar destructions. So bronchioles basically is asthma problem. So any disease, you have insight. What causes the insight? A lot of people don't know. So people can tell asthma is sort of like a genetic component plus environmental. So some people are more predisposed to asthma because their family have asthma. For some reason, their bronchial is just so sort of like hypersensitive. You know how some people are a little bit more sensitive than the other people? It's kind of like the same thing. So some of the respiratory bronchial cells of people with asthma is more sensitive to other things compared to the normal people. So people with some allergens can cause the bronchioles to become constrict. So like smoked, allergens, anything can cause the bronchiole to become constrict. But the main underlying pathophys is that they releases all the cytokines So I'm going to talk a little bit about later about like what is a major players that causes this bronchioles to become constrict. So there's many cells that get involved. So we talk about eosinophils, which is a big players, and sometimes you can also have neutrophils and all mast cells. So all these cells have a role in the the pathophys of asthma. So that's why we have a lot of drugs that target all these cells. So which I will talk a little bit later when we go down. But then I think Hip already talked about one of them, like cromolyn is basically it prevents the mast cell from releasing the granules. And then later we can talk about leukotrienes, which is a major player, and also the other drugs that like the beta agonist and the long actin and short actin is to prevent the bronchoconstrictions. Okay, all right.
All right, so talking about the etiology, right? So majority of the asthma is caused by the extrinsic factor, like the environmental, and this can be also can caused by intrinsic factor. For example, metabolic stress can also cause asthma. And asthma is also associated with the genetic predisposition, right? The IgE mediated response to the atrophy. So this is the one of the key factor, or the eosinophil is the one of the major play in the our immune response to it. And there is three principal triggers, right? So allergen and environmental factor, infection, and psychological factor. So I think the most common trigger right here is the allergen and the environmental factors. For example, you have dust, smoke, you use aspirin, beta blocker, pollen. And infection is URI or ISV. And inflammation allows for the hyperreactivity of the bronchi and limited airway flow, and cause the symptom of the wheezing, chest tightness, cough, and difficult breathing. They all relate to airway obstruction and our immune response to a trigger. All right. Talking about incidence, so it's about like 5 to 10% of the population, and 7 million children, like from 5 to 7 years old affected by this disease, and 30 million American and 300 million people globally growing and have been affected by asthma. And it is more common in the like from 5 to 7 years old, and it's more common in adult women, African American, and African American have a higher rate of mortality due to the excess of decay and low income. Like this incident about African American, I think they have some genetic factor that contribute to their predisposition. And the asthma can also cause death in the United States, and it's about 5,500 deaths. So it's not this complicated. All right. So for clinical finding of asthma, it's like acute. It's most of all time the asthma can cause acute symptom, and general appearance of the asthma is a sign of respiratory distress, and they have to use up the accessory muscles, and rhinitis, that means the inflammation of the nose, nasal polyps, swollen turbinate, swollen turbinate, wheezing, prolonged prolonged expiratory phase, because this is COPD patient, so they try to prolong our them out. So let's make the air easy to cough out. And as we said earlier, they associate with the cough and the shortness of breath. You want to say something?
Okay. I can talk a little bit later about the nasal polyps, but there's a very specific conditions where, they found asthma with the nasal polyps. Okay. Okay. Yeah. You go ahead.
All right. For differential diagnosis, so it can be related to in children. For differential diagnosis in children, it can be, go to the upper airway obstruction, small airway obstruction, and recurrent cough. So with the upper airway obstruction, we already say that it's allergic rhinitis, sinusitis. With the airway obstruction, it can be frozen body aspiration, vocal cord dysfunction, vascular ring laryngeal web, or airway obstruction from lymph nodes tumors. With the airway obstruction, it can caused by virus, and recurrent cough is may like related to aspiration or GERD. And in adults, it may relate to COPD, chronic heart failure, pulmonary embolism, tumor, some medication like ACE inhibitor that can cause cough, right? And pulmonary infiltration with the eosinophil. So because like eosinophil, because when I would like to talking about the immune response a little bit. So whenever we have exchanged allergen, they will activate our macrophage, right? The alveolar macrophage. The alveolar macrophage will go into a lymph node and activate the CD4, and CD4 will differentiate into Th2 cell, and Th2 cell will secrete a cytokine IL-4 to IL-4 to class switching up the antibody to IgE, and they also secrete IL-5 to recruit eosinophil, and another cytokine also released from mast cell, and the mast cell release histamine. All right, and a social environmental consideration. Adolescents have a poor rate of the compliance, so that means like they might not take medication when a symptom happen, or a mild symptom are less likely to get ongoing preventive care, or have an action plan, or know what to do or when to initiate therapy when symptom occurs, and chronic illness issue, and also a cost of medication, right? Like Albuterol, like $50. So it's also related to the financial. And with those who don't have insurance or lack access to the quality of healthcare, will also have a poor outcome. All right, for diagnosis or lab testing, we also need to find out eosinophilia, right? As I said earlier, our immune response will secrete some cytokine IL-5 to recruit eosinophil and elevate IgE, right? Th2 cell will secrete IL-4, and IL-4 is class switching to IgE, and we can also to the lab to determine hypoxemia. Hypoxemia, that means like it's low O2 in the blood, because as we know, a membrane alveoli can be getting thickened. So that's why they limited the O2 get into the lung. And we can also use spirometry, right? Because we use spirometry because asthma is belong to COPD. So with the COPD, it will hallmark on review a ratio of FEV1 over FVC. So that is a very characteristic of the COPD, and can also we can also measure forced vital capacity and forced expiratory volume. So I think I think this value will increase. Yeah, I know for the forced expiratory volume will be decreasing, and for vital capacity will increasing, but I'm not sure. I may go to double check on this. And we can also use the methacholine to do a diagnosis for the asthma. All right, next one. All right, for this is a treatment guideline, right? So like from what I learned right here is from what I learned in our school is for a long-term asthma, we use inhale short-acting beta agonist like albuterol combined with the inhale corticosteroid, right? So we want to bronchodilation, and we also want to suppress our immune response. For acute exacerbation of the asthma, we use inhale short-acting beta agonist again like albuterol, inhale short-acting muscarinic agonist like ipratropium, and systemic corticosteroid, and supplement oxygen. So and also we also need to identify, right? And we also need to identify, you know, like what is a trigger. What is a trigger, so we can remove a trigger, so we can stop our immune response, and a symptom will get in better. And control of our exposure. And we also can pay attention and identify to a drug reaction. Like some people can, you know, have asthma by taking aspirin or by the blocker. Food allergy, right? Some people have allergic to peanut or seafood can also relate to the asthma. And we also have daily monitoring a P of respiratory flow record, and we have to have a plan for a symptom when they go to a crisis. All right, Kato.
Oh, okay.
I think so, this is right.
Yeah, this is my slide. I will go a little bit more about like why specifically beta 2 blocker, like by going to the autonomic innervation of the lungs, because I feel it's gonna help to know why we use like beta 2 blocker, beta 2 agonist. I'm sorry, beta 2 agonist, or why we use anti-muscarinic, anticholinergic drug. So talking about like the innervation of the lungs, so the parasympathetic receptor in the lungs is M3, and it's present in the smooth muscle, and the lung, you know, comprises smooth muscle, and the function of M3 receptor are contraction of the smooth muscle and cleanse, and when it contracts too much, it can cause asthma. So that's why we use anticholinergic drug to treat asthma, and one of the drug is ipratropium, which in the next slide we'll see about that. But we also have the sympathetic innervation, which is mainly beta 2 receptor. As you can see in the table, which is taken from my school PowerPoint. The beta-2 receptor innervate the vascular bronchial smooth muscle, the liver and the skeletal muscle, and the effect of the beta-2 receptor in relaxation. So that's why we have the beta-2 agonist receptor, which is increase the function of beta-2, which cause the bronchioles is more relaxed, easy to breathe. So the current first line of treatment, can you go to the next slide, please? So that's why the first line of the treatment here is a short-acting beta agonist, because it provides a, it's act directly on the beta-2 receptor, and it relieves the symptom and prevent exercise-induced asthma. And one of the prototype drug is albuterol, and that is the short-acting. And like I say, because we have the parasympathetic innervation in M3 receptor, so the ipratropium is acting on inhibit the M3 receptor, so it can use in the combination with SABA. For SABA is short-acting beta agonist for acute treatment. However, because it's blocking on the sympathetic and parasympathetic receptor, so it also may have like some serious side effect. And one of the side effects for using albuterol, which is the beta-2 agonist, is you may have tachycardia, which is the how to say tachycardia? How to say it in Vietnamese? Like tim đập nhanh.
Yeah, I think so.
Yeah, because in the reverse table, as you can see, we have like in the heart we have like beta-1 innervation, and when we use beta-2 at the high dose, it can also activate beta-1. So that's either one of the side effects when you use beta-2 agonist drug. However, using it at inhalation, so the albuterol, which reduce the side effect of tachycardia. Also, like Anhip say that we also use corticosteroid to reduce inflammation from like overacting macrophage and eosinophil. So we also use prednisolone and other. I don't know much about corticosteroids, so Hip and Anhong will say more about that.
Yeah, I would talk about that later.
Yeah. I'm not sure about like the second line, but the long-acting beta agonists, we have salbutamol and formoterol. Like I say, because they are both beta agonists, and so if you use for a long time, it can lead to like severe outcome. One of the outcome have been done with one of the side effects have been done with the beta-2 agonist, like I say, is tachycardia, and other like mostly. Like you guys have anything to say, add into it?
Okay, I think it's easier next time when you add a little pictures to it, because these are all words. It's very hard to follow. But I have a couple of slides about the pathway later. So just go ahead and finish, and then we can do some question later.
All right, so there is some complication associated with the asthma, right? So this is the first one is the atelectasis, right? Atelectasis, I mean the alveoli is collapsing. It might be due to a surfactant or the a rupture of the alveoli. It can associate with the pneumonia, and it can associate with the pneumothorax, right? It can, because like sometimes the alveolar infection can cause the spontaneous pneumothorax. Then medication specific side effect or adverse reaction, respiratory fail, and it can cause death. So how we go into the with the therapy for asthma? So it depends on it depends on the symptom and respond to a treatment. So there is like for asthma treatment we need to have the long-term goal and the short-term goal. For the long-term goal, it's associated with a different kind of medication we will use for the long-term goal, and for the short-term goal, it's also have a specific medication and immunosuppression for short-term. And we also need to have a review daily self-schedule management plan, and also need to do some medical adjustment based on a symptom. So if a symptom getting worse, then we will increase a dose of corticosteroid, for example. Yeah, so we need to ask for our patient, like if they smoking or they relative in the household smoking, they need to stay away from smoking, or stay away have some prevention for the secondhand smoker exposure, and try to remove or identify any allergen or irritant that can trigger the asthma. And then can also treat for allergic rhinitis, and use inhaler with the aerosol chamber, and use some medication for it. All right, so with the asthma action plan, right, for the first one, we need to say monitoring the symptom. So through a symptom, we can know whether we in the intermittent state or in the severe asthma. And we also need to measure our lung function. Like, for example, we can measure by spirometry. And now if the symptom getting out of control, we need to go to see a doctor, medical emergency room. All right. So can you help me this out slide?
Yeah, so this is what they call in the hospital the asthma treatment plans. This really doesn't have anything to do with us as far as, it's more of how the hospital monitor the asthma. I don't think this is very useful for us. I think this is for more like the nursing side. Usually before you send the patient out of the hospital, they go through all this to make sure that everything is set up for the patient. All right, so I think we can skip that part. So let's do some question now, because I feel like asthma is so common, people know about it. But the thing is, what do they test you when it comes to questions? Okay, so I'm gonna share my slide, and then we can go to the questions a little bit. Okay. All right, so let's do the first questions. All right, so I'm gonna have someone to read it just so that you guys know how to pronounce things a little bit. All right, let's pick, anyone want to read it? Okay, Hoàng Vũ, you can go ahead.
A 12-year-old girl presented to the ED with a difficulty breathing after playing soccer outside in the cold. The couple seemed to have the same problem according to the mom. On the examination, her respiratory rate is 24. She is apneic and with the intercostal retraction. The chest is hyperresonant to percussion. Respiratory wheeze are heard on the auscultation. The BFF show a decrease in the FE1 over FVC ratio. Which of the following is the underlying pathologies of the patient lungs?
Go ahead, just read the choices.
Yeah, I will read the choice. A abnormally dilated bronchi with mucus and neutrophil. B, the hypertrophy and hyperplasia of the mucus secreting gland in the bronchi. C, dilated air space with the alveolar wall destruction. D, intra-alveolar hyaline membrane composed of fibrin and cellular debris. E, mucoid exudate forming a cast blocking in the airway.
Okay. All right, first, before we go, the PFT is short for pulmonary function test, basically just testing how good your lungs are. All right. So what do you guys think the patient has? The first question. It's not a tricky question. We've been talking about it for an hour. What do you think the patient has? Vote.
Yeah,
What do you think the
see
patient has?
it.
All right, so let's look at the age.
I think, yeah, I
Okay.
think not dilated. I think it's
So before you
description.
answer the questions, like I want to see what do you think the patient has before you even look at the answer choice.
Yeah, I think the patient have asthma exacerbation.
Okay, so what makes you think that the patient have asthma?
I think because the patient is 12 years old and present with dyspnea.
So young, okay, dyspnea.
Young, yeah, dyspnea, and it was triggered by exercise.
Okay.
And he present with the sign of respiratory failure, increase the respiratory rate, and intercostal retraction.
Yeah, but that's all the lung, respiratory problem will have the same symptom. But what tell you exactly is asthma?
Yeah, the chest is hyper resonant is glued too, and the lung function test.
Yeah.
So the
So the lung function test is decreased. Yeah. Okay, so that's a sign first. So if I tell you that the lung function test decrease, what does that put into restrictive versus obstructive lung disorders? You know what I'm talking about?
Yeah, I know that.
Okay. So the ratio is less than 70%. Is that obstructive or is it restrictive?
I think it's obstructive.
Okay, yeah, so just think about like the ratio is low, I mean that something is obstructing the airway, right? Okay, so there's only a few things that fall under the obstructive pattern. So COPD, chronic bronchitis, right? And then the emphysema, asthma, bronchiectasis. So if you look at this, you see that the expiratory wheezes, and then the patient is 12 years old, and also the brother also has the same problem. So it's like, inherited disease. So all of those symptoms, they point toward asthma, okay? So now, the question talking about asthma, and now we have to understand what is the underlying pathology of asthma, and what do you think one of those 5 choices is asthma?
I think the two component that's in the pathology in asthma, it is the inflammation and the constriction.
Okay.
Yeah.
So A, B, C, D, E, which one?
Yeah, maybe D.
Maybe D? Okay. It's close. Yeah, it's close. It's good job. Okay. Hey, what do you think? These are questions that you're going to be answering.
I think E.
Okay. All right. I can explain.
Because B is not really right. Because B, I thinking about the chronic broncho something.
Okay, so so remember when I talk about respiratory.
Not bronchi.
Yeah. So when you think about lung, problems, you always have to divide it. Where is the problem? Is it upper? Is it lower? Or is lower down? Okay. So remember when I talk about asthma, it's been bronchial, right? And upper is bronchi, So A is talking about bronchi, right? So we have abdominal dilated bronchi with mucus and neutrophils. It's in the bronchi, so it's definitely not asthma, right? The same thing with B. It's also hypertrophy and hyperplasia in the bronchi, so it cannot be asthma, right? So you come down to C, D, and E, right? And then again, C is what? An alveolar problem. So most likely it's probably like COPD or emphysema. It's not asthma. Again, you have to think about the bronchioles. So you come down to D or E. So it's very tricky because D, when I think about hyaline membrane, it's only one condition that can cause that, the ARDS. It's hard, but you have to remember the keyword. If you see intra-alveolar hyaline membrane, that's ARDS, okay? So, and then just come down to E. So a lot of inflammation in asthma, it causes the lining of the bronchiole to become separated, so that, the mucus secreting a lot of mucus and it blocked the pathway. So that's why a long time ago, when you go to the hospital, when people have asthma, you see a lot of people just slamming on the back just to get the mucus out. So, so that's why E is a correct answer. Okay, so,
nice.
Again, so A would be bronchiectasis. Again, you have to remember all of this, okay? So when I say decrease in the PFT, the ratio is decreased, then it put it into the obstructive lung patterns, okay? So you have to think about bronchitis, emphysema, bronchiectasis, okay? And then asthma. And then just know that asthma is due to inflammation, irreversible bronchoconstriction, and sometimes it also have mucus blocking the airway, all right? So that's the first question. So the key, how to answer this question, again, decrease FEV over FVC, think about obstructive lung disease, okay? So that's how you think about how to solve the questions. So it put you into COPD, bronchitis, emphysema, asthma, and the bronchiectasis. And then you have to figure out like which one is which, all right? So bronchitis, again, is like inflammations with a lot of mucus. So a patient coming with cough, tons of mucus, and then you think about, and no reason, which is just, cough with mucus and bronchitis. Emphysema is someone who smoke a lot, usually an odor, and then you think about a destruction of the alveolar walls. So you think about that one. And when you do a chest x-ray for someone who has emphysema, think about, flattened diaphragm with hyper-resonant percussions, and then with barrel-shaped chest, okay? Then asthma is reversible bronchospasm with a lot of triggers. So when you think about triggers for asthma, think about cold air, allergens. So young patient with episodic wheezing, somebody in the families have the same problems, and you think about asthma. Then bronchiectasis is very serious. It's sort of like, infections. So think about necrotizing infections, and their airways permanently dilated. And these are people that already have, sort of pre-existing lung disease like cystic fibrosis, other like carcinoid syndrome. So they are at risk for recurrent infections, okay? All right. So, and the one on the right is talk about what sort of trigger that can cause asthma. So think about, pollens, animal, like pets, all right? So dust mites, cockroaches. And then cigarette smoke is a big one. So you think about that, okay? Someone in the house smoking could trigger asthma. The other one is air pollutants. Sometimes we don't think about it. We live in, a very polluted places, then people tend to have more asthma. Infection can also predispose to asthma, but it's sort of like a different mechanism that causes you to have asthma. And there's a couple of medication can cause you to have asthma, and one of them is aspirin, which we can talk about a little bit about later. And also the other one is non-selective beta blockers. You know why non-selective beta blockers causes asthma? I think Katu talked a little bit about it earlier.
Block the beta 1, 2.
So why the beta blocker is called asthma?
Because block beta 2 receptor.
Yeah.
And beta 2 receptor occurring relaxation in the lung, and also if it blocking beta 2 receptor, it can increase the action of muscarinic receptor and muscarinic C receptor, known for constriction of the of the smooth muscle gland.
Okay, so what is a beta blocker used for in general?
Treatment of heart disease, like hypertension.
Hypertension, yeah, great. So tell me how does beta blockers help with hypertension?
Because the heart is innervated by by beta-1 block, beta-1 receptor,
Mm-hmm.
and beta-1 receptor in the the SA node and AV node, and it increase the contraction and the heart
Mm-hmm.
rate.
Yeah,
So
but
by
that's heart rate.
blocking,
Yeah, that's not high. That's the heart rate. That's not the hypertension. So hypertension is blood pressure within the blood vessel.
Yeah, also like alpha-1 receptor of the
Mm-hmm.
sympathetic system, lining the vascular vessels, and beta-1 it constrict action of sympathetic system.
So that's why I always
the blood vessel.
So you think about beta-1 and beta-2, okay, and then alpha.
Yeah.
Okay, so beta blockers block the vasoconstriction, so that's why they help the blood to dilate a little bit, so they help with hypertension. But unfortunately, it causes the lung to to constrict. So that's why when you give someone with hypertension, you don't give them like the non-selective beta blocker. You have to give them selective, because if it's non-selective, then it could affect the lung also. All right, and then the other one is cold air and the dry air. So often anything that irritates the lung will cause the lung to cascade down the spiral, so it become inflamed. Once it becomes inflamed, it activates other cells, and other cell releases more inflammatory cytokines. So it's like a pathway. And then GERD can also cause this sort of asthma too, because GERD is acid reflux. So sometimes it can irritate not only esophagus but also the surrounding lung tissue. Okay, and stress is everybody know that stress can cause anything. All right, so next question. So when you guys do a question about the lung pathology and they give you the FEV over FVC, so always put them into different buckets. Think of low ratio versus normal or high ratio. So when it become low, then you think about obstructed only, and if it's high and normal, you think about restricted only. Okay, so if it's obstructed, then you do the bronchodilator challenge. Right, so if you see that if the FEV is increased, this is actually what they do in the hospital, right? They come in and then you give them one of those, like the bronchodilators, and then all of a sudden they become better. Then we think about like, oh, it's something reversible like asthma or COPD. All right, so if you do a challenge, if it's increase in asthma or COPD. All right, so second question. So let's say the first patient that we have is diagnosed with asthma, and then we collected her sputum, right? And then we sent to the lab, and then we stain them and put them under the microscope, and this is what we see. So I want you to name these, because they will test you. Sometimes they will just show you a picture of this. This is taken out straight out first aid. I had the question about this, so that's why I put it up. I got a question about G. They put me a picture of G. If you're starting for step 2, so I'm gonna let you answer this one.
I think it's related to the eosinophil new eosinophil new process.
Okay, I mean you got the eosinophil, that correct? That's fine. Why do you think it's eosinophil? Because
eosinophil is the one of the cell involved in our immune response in called asthma pathology.
Yeah, and what color is the stain that you see?
Black.
It's pink.
Pink.
Yeah, eosinophil, when you stain it, it becomes pink because of the granules they have. All
so
right,
what the black one?
That's not really black. It's just because of it's too pink.
It's basophilic, right?
Yeah, so it's too pink, so that's why it become like a little bit black, but it's not really black. You see the stain is pink, so that's why. All right, so just remember this. So when you do you stain the sputum, sometimes they have this, they call it Kurtzman spirals. Basically, it's just a shut epithelium with sort of like mucus plugs. It's plugged together, so it formed that. But the more common picture that they show you is G. They call it chocolate-laden crystals. I absolutely think you need to know this one because they show it to me. And also in the hospital, sometimes you have TAM that you can collect the sputum and run down the lab and see it. So it's sort of like, remember gout? is sort of like the crystal like that, but this thing is more of an eosinophilic double-pointed needle-like crystal, and these are composed of eosinophils in the sputum. Okay, so you're correct. Eosinophils is the main players in one of these asthma pathology. All right, so this is straight up from first aid. So you have to remember this. If the only two things that you need to remember about histology for asthma, remember the Kurtzman spirals and then the chocolate-laden crystals. All right, question 3. So most of the cases of asthma occur due to a combination of environmental and genetic factors. Which of the following is the major mediator of asthma? It's leukotrienes, eosinophilic chemotactic factors, is it major basic protein from eosinophilic granules, is it macrophages, E, I don't know. All right, who want to answer this? All right, I'm going to pick mate. Give it a try, mate.
I think the answer could be B.
Could be B. Why do you think it's B? Can you remember I say about eosinophilic? Eosinophil?
Oh.
You are correct. It's, you know, it has to do with eosinophil, but the reason why I put major mediator, what are some of the drugs that help with asthma? Can you name some of the drugs? Okay. So
Aspirin.
So SABA, which is a short-acting, right? The beta agonist, all right? A long beta agonist, okay? And then the anti-muscarinic. So those are acted on the muscle, right? It doesn't have anything to do with the cytokines, you know, that released by the inflammatory cells. But what are some of the drugs, the other drugs that help with asthma?
Montelukast, right?
Yeah, so montelukast, what is montelukast?
Yeah, it is the leukotriene modifier.
Exactly. So remember, they don't make drugs for no reason. So all these drugs have to target something, right?
Yeah.
So that's why I want to bring you to the most important slide of this whole lecture. It's basically, it's the leukotrienes. Just remember, it's triggered the contraction of the smooth muscle, and it causes like inflammation everywhere. But let's go to this slide, okay? So this is a slide that helps you sort of think about the role of leukotriene in asthma. So when you think about asthma, think about leukotrienes, okay? So how the leukotrienes are produced. You remember the arachidonic acid, which is the AA, the same pathway that make leukotriene, but also make another sort of prostaglandins. You remember prostaglandins at all? Okay. So the role of leukotriene in asthma is well studied. Okay, so first it's formed by eosinophils and also mast cells. So remember chromalin, which is the mast cell inhibitors, right? And then we have the eosinophils, which can be activated, and then all this will release the leukotrienes. And the leukotrienes we call inflammations. And what does inflammation do in the bronchioles? It causes the bronchiole to become vasoconstrict, and sometimes it causes the airways to release histamine, and sometimes the mucus is produced, so it's blocked the airway. So not only the airways are constricted, but also it produces mucus, and it's become, so the diameter of the airway become even less. So that's why you have trouble getting air in. So that's why when people wheezing, they cannot get any oxygen in. And some people, they become so bad that, you know, become respiratory failure. So that's why you have to sort of, you know, put them on the machines. You have to, what do you call it? Put you know, a tube down their throat to help them breathe, because they cannot breathe by their own. So leukotriene does two things. First, it called bronchoconstrictions. The second thing it does is attract other cells to come. So it's sort of like a chemo attraction. So it helps recruit eosinophil and neutrophils to come to the site, and these will causes more inflammation to occur. Okay, so that's why. So the leukotrienes is very crucial. So that's why you can have the one of the target for asthma drug is a 5 the LOX enzyme. So we call it a 5 lipoxy lipooxygenase. So you block that enzyme, you cannot make leukotrienes. So let's go. Okay, so just remember that 2 drugs, the montelukast, right? That's a leukotriene inhibitors, and also we have the other one, which is the 5 lipoxy oxygenase inhibitors. Xyloton, you guys know Xyloton? No? Okay, so Xyloton is the inhibitors of the enzyme directly. The montelukast is block the leukotrienes. Okay, so it blocked the leukotriene over here, but the Xyloton block the enzyme, so you don't even make leukotrienes. Okay. All right. So next questions. This one is very interesting. So you have a 50-year-old man who presents to the ED because of acute shortness of breath. Okay, and that started while he was shoveling snow in his driveway. So the patient is generally healthy, and he was started on a new medication this week after his general checkup with his doctor. He has never had similar symptoms before. On physical exam, he has labored breathing and wheezing bilaterally on both lung fields. On physical exam, they found that he has nasal polyps present in his right nearest. A chest X-ray is normal with no consolidation or infiltrates. So which drug is responsible for this patient's symptoms? Is it aspirin? Is it lisinopril, corticosteroid, penicillin, or theophylline? All right. Who want to give it a crack? First, what does the patient has? What do you think the patient has? Yeah, I'll give you a hint, nasal polyps. There's only one thing that involved in nasal polyps on step 1. Maybe you know what it is?
No.
No? Okay.
Yeah.
All right. It's okay. All right. So let's go through it. So first, let's go to the drug. Okay. So aspirin. What is aspirin? We talk about aspirin all the time.
COS inhibitor.
Okay. Good. How about lisinopril?
It's a ACE inhibitor.
Okay. So what does it do with? What does it help with?
It treats hypertension. Is it inhibit the conversion of
ACE.
Of ACE angiotensin to 1 to angiotensin 2.
You know what's the common side effect of ACE inhibitors?
I did not see that.
Cough, exactly. So cough, yeah. All right, so cough. How about corticosteroids?
It's an immunosuppression.
All right. Okay, so penicillin is just antibiotics. Theophylline. What does it treat?
Asthma.
Yeah, so asthma. Okay. All right, so this you need to know because they always do it. They always put it on step 1. So basically, what is presenting is that you have to know the triad. Okay, so asthma with nasal polyps and recent exposure of aspirin. So this is aspirin-induced asthma. So do you know? Does people know why aspirin causes asthma?
I know.
Yeah. How? I showed you the answer right on it. It's the image right there.
Can I give it a try?
Yeah, go ahead.
So aspirin acts on blocking the cyclooxygenase, and so it's blocking like prostaglandin and thromboxane. So when it blocks one pathway, it will shunt in like the metabolic will shunt into another pathway. So it like increase the leukotriene A4 pathway and leukotriene onto like asthma. So that's why. Yeah.
So remember the AA, which is arachidonic acid, is a common pathway for both prostaglandins, thromboxane, and leukotriene. So you have a COX inhibitor, which is a aspirin. If you block one pathway, it will shunt all of the ingredient to the other pathway. So just remember, if you block one pathway, the other pathway have more. So remember leukotrienes, our friendly friends for asthma. More leukotriene is not good for asthma. Okay, so that's why if people take aspirin and they become asthmatic, I mean they have symptoms, like shortness of breath, and then you look into the nose and you have nasal polyps, then you think immediately about aspirin-mediated asthma. Okay, so that's only one condition that have nasal polyps in it. So nasal polyp, think about aspirin asthma. All right, so I think the most important part about asthma when it comes to step one is knowing the drugs and how does it work. So we talk about asthma, basically it's a reversible bronchoconstriction, and it acts via three pathways, right? So first is general inflammation. So when your airway become inflamed, it just automatically it become constricted, and sometimes it causes the mucus to produce, or it causes the airway to become even smaller. So that's why one of the ways to decrease the inflammation is corticosteroids. Okay, so corticosteroid is like the last stop. Like if nothing else works, then you have to use corticosteroid, because that will. The reason why, because you have a lot of side effects and it works on everything. So it's sort of like a last ditch effort. So that's why when you treat stepwise, so you have like sort of like intermittent, and then you have severe, and then very severe. And you only use oral corticosteroid with the last step. You can also use, they call it inhaled corticosteroid. That one is a little bit better because only act on the nasal mucosa. So when you inhale it in, it's only act on your respiratory system. Okay, it doesn't affect your general system. All right, so that's the first one. It's decrease inflammation. So think about corticosteroids. And then the second one is cytokines. So we talk about cytokines a lot. So what are the most important cytokines you need to remember for asthma is the leukotrienes. Okay, so there are three things you can block. The first one is montelukast and zafralukast. Remember, we talk about the lukast. So when I think of lukast, something with anything lukast, I think of like a caps that it put on the leukotriene. So you put a caps on leukotriene, it doesn't work anymore. So just like a trick to remember. So anything like montelukast, zafralukast, think about leukotriene receptor blockers. So it put a caps on the leukotriene receptors. Okay, and then above it, before you make the leukotrienes, you need the enzyme, which is the 5 lipoxygenase inhibitors. So the Zolatan. There's no way I can sort of have like a mnemonic to help you. Just remember Zolatan is a 5 LOX. We call it a lipoxygenase inhibitor is LOX. And then the other one is block the omalizumab. What's the drugs when you read the anything with the MAB at the end? You know what it stands for?
It's an antibody.
Yeah, so monoclonal antibodies. So this is a new drugs. It's blocked cell activation via the anti-IgE. So it blocked the IgE and it just stopped the cell from activated. So it mainly acts on mast cells to become activated. And I think we talk a little about the constriction of the smooth muscle. Okay, so the whole problem is caused by the smooth muscle become constricted. So it will help if you can stop the construction of the smooth muscle. And one of the drugs that do that is the albuterol. So I do talk about it before, is the beta agonist. So beta agonist, it help dilate the smooth muscle in the lungs, but it causes vasoconstriction in the endothelium cells. Okay, so they have two separate functions. Just to remember that. So beta causes vasoconstriction in the vessel, but it causes vasodilation in the lungs. So the first one is the short-acting, so we call it SABA. So short-acting beta agonist, which is sort of like we call it the rescue inhalers. Everyone have it. ProAir, I think in Vietnam they use the same thing too. And then long-acting is a little bit different. So just remember anything that after albuterol is long-acting. Theophylline. So let's talk a little about the beta agonist. So what does a beta agonist do, right? So when you have ATP, which is the cells, the energy block for the cells, is break down by adenocyclase, which is AC. It causes it converted into a cyclic AMP. So you sort of have to go back into the smooth muscle contraction. So they have three different muscle, right? So you have cardiac muscle, you have smooth muscle, and then you also have skeletal muscle. So there are three different muscle, but in cyclic AMP, smooth muscle, elevated concentration cyclic AMP causes the bronchodilatations, okay? So beta agonists would cause a pathway, so that's why we use it, the SABA and the LABA in that way. But also, the cyclic AMP, it can be break down by the phosphodiesterase to become AMP. So that's how theophylline works. So it blocks that enzyme. So instead of being degraded into AMP, now you have more cyclic AMP. So it helps with the bronchodilations. Okay. And then the thing that we talk about, the muscarinic antagonist. So remember, smooth muscle or even skeletal muscle, you need acetylcholine to cause it the contractions. So if you block that pathway, you block the acetylcholine, then you end up with the smooth muscle not contracting. So it helps with the vasodilation. Okay. So remember the tiotropium and the ipratropium. So when you remember anything with the opium to it, is sort of like it's stop the smooth muscle. So opium, like you feel good, so you kind of relax, right? I don't know, you know, opium is like a
opioid.
Yeah, like opioid. So it's help you, you feel good, so your muscle just like relax. Okay.
Now I have a quick question.
Yeah,
so I'm seeing in practice, like a lot of doctors prescribe montelukast to treat allergy. So does what intrinsic property of montelukast that can treat allergy? The allergy have high concentration.
What allergy?
Like seasonal allergy, very bad seasonal allergy.
So they say use the same pathway, right? The leukotriene receptors. So remember we talk about the atopic triad. So we have allergic dermatitis, and then you have asthma, and then you have the last one, which is the allergic rhinitis. That's what people have because they have rhinitis. So that's the seasonal allergy. It's caused by the same thing, sort of hypersensitive cells that releases the leukotrienes. So that's why the leukotriene helps with that.
Okay, thank you.
Yeah, just block the leukotrienes. That's where all the all the allergic reactions comes from. So when you think of allergy reactions, so the 3 cells, like the mast cells, right? Mast cells, neutrophils, and then eosinophil. One of those 3 cells. So leukotriene block the. All right, so when you think of asthma, I want you to think of this way. Step 1 will not test you the diagnosis a lot, but sort of like you have to know the treatments, mostly for step 2, but it's also help with step 1, 2. It's very complicated, so this is more like a simplified, way to remember it. So when you think about asthma, you have to put them into a category, okay? Either whether it's intermittent or it's persistent, okay? So intermittent means that it's happened throughout the day, maybe a couple of times, but it doesn't happen every day. So the patient could have like just once a week or twice a week. So when I think of intermittent, think of somebody just have episodic asthma, maybe once a week or twice a week, but usually no night symptoms at all. So on the test, they will make it very, clear that the patient have intermittent. Okay, so then we think about persistent. So you put it into the bucket of, is it mild, is it moderate, or severe? Severe, everybody knows. Severe means that you just have asthma all the time. Like you cannot breathe even the day or at night. So that's severe. Okay, and then now the problem is how you separate between mild and moderate. So the thing that I try to help separate between the two is daily. If you have daily asthma, like daily symptoms every day, then that put you into moderate persistent. Okay, so that just remember that if you have asthma every day, either you have moderate or severe. Severe means that you are sick, like you have to be in the hospital. If the patient can still breathe, okay, and then they can come to the hospital themselves, then probably that's moderate persistent. So the reason why we have to put into different categories because the treatment for it is differently. So if you have intermittent asthma, then you only need the rescue inhaler, which is a short acting. So when you have trouble breathing, just take a puff and you'll be okay. So that's intermittent. And then when you have mild persistent, then you go up one ladder. Okay, so I want you to remember the mnemonic silo. So that's how you go. That's how you escalate the treatment for asthma. So S stands for short-acting, I stand for inhaled corticosteroids, LABA stand for long-actings, and O stand for oral steroids. Okay, so if you have intermittent, just give SABA, just the short-actings. If you have mild persistent, then you give SABA and you give the inhaled corticosteroids. Okay, and you have moderate persistent, and then you do SABA, and then you do the inhaled corticosteroid, and then you do the long-actings. And remember, inhaled corticosteroid have different doses too. It's have low dose, medium dose, and high dose. Okay, and then for really severe, that's the only time that when you use oral steroids. So you know, put them on the oral steroid taper. And then the other treatment is alternative treatment. So remember, we talked about the leukotriene receptor antagonist. Okay, know how it works. Theophylline, know how it works. Xylitol and omalizumab. Also, that's a new drug. Also, that's usually for treated people with like exercise induced asthma, or that's more like allergic kind of asthma. I think someone have a question. Someone asked me if any experience used magnesium sulfate in severe asthma. I actually never heard of magnesium sulfate used for severe asthma. Interesting. Can someone look it up for me? Magnesium sulfate for asthma? I thought that to use for maybe like TCA, tricyclic, like toxicity. Yeah, I'm not sure about asthma. I only remember magnesium is TCA toxicity. Okay, so this is a real treatment. See how complicated it is? It's so complicated that even I don't remember. Sometimes, like some of the doctors in the hospital, they just go and they look. So just so my easier way to remember is just go back here. Okay, just go silo and then remember. Very severe. I mean, the patient is in trouble. They have daily symptoms, and think about moderate, persistent. When they only have like from time to time, but really no nighttime symptoms, and think about intermittent. Okay. All right, so there's a lot to talk about asthma, but I think the most important slide is you have to understand the treatments for asthma, because that's how you're going to be tested. Most likely just mechanism, how it works. And just remember the asthma-induced attack, when you see a nasal polyps and then they have trouble breathing, see if they have any recent exposure to aspirin. And the reason why I put aspirin over here is the patient is 50 years old man, so he probably has some cardiovascular disease. So the doctors put him on aspirin, to lower down the risk. Okay. All right. Any question, guys?
So I just do a quick research about like magnesium sulfate. So it's more commonly used in the North Pacific rather than the Western. And the literature review just say that use as an adjunct to standard treatment may be beneficial in the treatment of adult patients with severe or life-threatening. But the role of nebulizer magnesium sulfate is less evident due to insufficient evidence. So yeah,
good to know. Okay, any other questions? I know it's a lot. Asthma is not easy because it's very complicated. There's so many drugs, but that's the thing. You have to know every single drugs, like what it does.
So this is a real case I see in the clinic. My patient has ASCVD. And she has like pulmonary regurgitation, and she has symptoms that I pretty much like, not like she has a history with asthma, but now like she present to our clinic with 3-month ongoing cough, and she had a very much symptom of asthma, but like she told me that the cold weather make her feel better. So I don't understand that part. So so in that case, is using beta-2 agonists going to help her given her history with the heart disease?
I'm sorry,
we try
so she has heart disease?
Like she had like the ASCVD, the pulmonary regurgitation. She also had murmur.
And I
And
still don't understand the question yet. I'm sorry.
So she had like complication revolving her like her heart, you know, like of the ASCVD, the pulmonary regurgitation, and she present to a clinic with the complaint that pretty much like asthma symptom. And so my question is, can we use beta agonist for her or not?
Honestly,
because like when I asked like my MIM3 say that we cannot because like it's risky to give her beta 2 agonist because of her heart. But like my understanding is if you are just acting on the beta 2 and then the heart was innervated by beta 1, then why the complication here? Like I just don't understand the connection between the two. So can you explain more?
Well, first of all, I still don't get it, like the underlying problem with her heart disease. Does she have like congestive heart failure, or what does she have like? So I don't understand what do you mean by, does she have asthma or?
She had a history of asthma.
She have history of asthma, okay? Yeah.
Yeah, but and she presented to the clinic with the symptom that very much like
so
asthma.
The patient have asthma, and then the patient also have heart problems, and they don't want to use basically the beta agonist. Is that the question?
Yes. Yeah. So
that's a very
like, why
good,
can't you use that?
So that's a very good question. What's the side effect of the beta agonist? What do you think? Yeah,
but we know that. But like, if we use the like tachycardia, and if but it's less severe if we use it inhalation rather than like pill. And also like if we use correct doses, because
that's still a risk for the patients. So if the patient have the heart problem already, their heart is already at risk of become more, weaker. So you don't want to. The problem is if your heart become weaker, right? You end up with fluid backing up into the lungs. That will cause her asthma to become worse. So I think people don't try to treat the underlying heart disease by messing up with the medications. So the heart is very tender organ. So you don't want to mess it up because there's other medications to treat with asthma. So why stick with one that can cause us the side effect to the heart? Right.
The problem is like we are not really sure that she had asthma. She had asthma-like symptom, but when we ask her about like whether the symptom get worse.
Yeah. So if you're not sure the patient has asthma, I don't think it's good for the patient to you try to risk that to treat asthma, because you're not sure the patient has asthma or not. So why treating them?
Because I think it's at the last thing to try, because we try her on Montelukast, Singular, and other bunch of like GERD. We try her on like
okay, so let me ask you this, right? Let me ask you this. So is her symptoms very severe that she have to be hospitalized?
It's severe enough to distress her from life. Like her quality of life is very like heavily impacted. She could not sleep. She had to sleep upright.
So do you think that's the heart problem, or is that the lung problems?
Like we think it both, but currently like because she presents to a student clinic, she doesn't have insurance, so we cannot do anything with her heart surgery or anything. So that's why we try to tackle it. Yeah, so that's why you have side.
So people prioritize, right? When you see the heart problems, you treat the heart first, because if you treat the heart and she still have problem in the lungs, that means there's something wrong with the lungs. So that's why you treat the heart first to see if her symptoms improve, right? And then if it's improving, that means that it's her heart. So, and then you can try to walk backward. If you treat the heart and it doesn't work, then it could probably her asthma. But in general, I think people try to attack the heart first. So any problem, when you have a weak heart and all of a sudden you have pulmonary edema, people will also treat the heart first. You don't treat the lung first, you treat the heart first. So
yeah, it's just tough.
Let us know. Yeah, let us know how it goes. But I think that's the general thinking.
Okay.
All right.
Yeah, and I think even the patient have the heart failure, but in the situation like Do described that maybe she have heart failure exacerbation, and in that and in that situation, we avoid to use the beta blocker for her.
Yeah. So
because
we also
like
did,
you're right.
We also did her EKG, and her EKG is good. There's no change from last time. That's why I don't think it's like chronic heart failure. But I will update you on that.
Yeah, but very good. You know, like I want you just actively thinking. You know, so that's good. Okay. Any other questions? I think asthma is very interesting. It's very, so let me ask you this one last question before we sort of, end the class. There's one physical exam that you can do for someone who has severe asthma. Do you know what it is?
What?
Okay, physical exam. Okay, have you heard of the term called Pose's paradoxes?
Yeah, I heard that, like in the cardiac tamponade, right?
Yeah. So, can you explain what Pose's paradoxes is?
Like usually when you in the situation of dyspnea, and you breathe in, and the vein on the jugular vein, the external jugular vein will collapse. But in the situation of asthma, there's an increase the pressure in the lung, in the thoracic. So when you're breathing, the pulse of the external jugular vein will pulse up. So we call that is the.
So what is Pose's paradoxes? What's the definitions? When you breathe in, if your systolic blood pressure drops more than 10, then they call it Pose's paradoxes. And there's only a couple of disease that you would have that symptoms. So like you say, cardiac tamponade is one, right? But also severe COPD and severe asthma. Yeah. So that's sort of just, something to keep on the side when you see on, like on the exam, when they think about Pose's paradoxes, then just keep thinking about cardiac tamponade, severe asthma, severe COPD. Okay. All right. It's been fun. Thank you. Thank you for the case, Thao. Hopefully that you guys can bring us more case next time. Sorry, asthma is so complicated. We didn't make our own slide. We sort of have to use someone else's slides. So it's not as good as our slides. But hopefully next time we'll try to make our slides, okay?
So
all right. Have a good
topic. The topic next time is.
I don't know.
I want to ask about the.
I don't know yet, but maybe I was thinking about the GI, because we talk about the lungs a lot, like tuberculosis, and we talk about skeletal muscle, maybe GI. So maybe ascending cholangitis, the whole shenanigans of the whole GI, like the gallstones, right? Cholelithiasis and cholelithiasis, so that's very useful because they are tested all the time. All right. So.
Okay. Thank you.
Bye.
All right. Good night, guys.